My name is Charles Argoff, and I'm a neurologist by training. I work at Albany Medical College in Albany, New York. I direct our comprehensive pain center and our pain fellowship. I'm also vice chair of our department of neurology and current president of the American Academy of Pain Medicine. And it's a real pleasure to be here to speak with you about, this is going to be focused on a particular topic, but I know that you're going to find this interesting and exciting. There will be a time for questions and hopefully answers, because hopefully all questions can be answered, and at the end. And we're going to be concentrating on the use of a medication called ZTlido, which many of you may be familiar. But by show of hands, how many of you have never prescribed a ZTlido patch? Okay? And so that's a number of you. So I hope that for those of you who have not been prescribing this, that you gain more information. And for all of you who have, that you gain additional information. So the title of the talk is Breaking the Vicious Cycle of Chronic Neuropathic Pain of PHN, with a subtitle of What to Do when Pain Relief from Gabapentinoids Isn't Enough. So just by show of hands, again, how many of you have noticed when managing a person with PHN that using gabapentin or pregabalin is not sufficient for their pain? All right. Okay, so almost all of you. And so we're going to cover the use of gabapentin and pregabalin in postherpetic neuralgia. We're going to think about the role of oral analgesics as adjuvants to gabapentinoids, and then concentrate the majority of our discussion today on a next generation topical lidocaine patch, which is the ZTlido patch, to optimize gabapentinoids. And there's some really interesting coming attractions. I don't know how many of you have seen this data before, but there's some really interesting data about actually combining a topical lidocaine patch with gabapentinoids. And then the potential for use, this is really exciting data because it's real-life claim-based data, a review of what happens when you use ZTlido, and also what happens if you use a different type of lidocaine patch, the 5% lidocaine patch, to reducage of the use of opioids, which is always, what seems to be is often important in optimizing the care of our patients. So just by a summary, I know that almost everybody in this room already knows this, but what happens when people experience postherpetic neuralgia as an example of a chronic neuropathic pain condition is that the pain over time, when it doesn't go away sufficiently, and we know that it can persist for years, can be associated with a debilitating outcome. And that can mean not being able to sleep, function in other ways, work, or otherwise be happy with one's life because of the pain. And that's a vicious cycle that we really want to try to break. And I don't know about you, but if I was in that kind of pain all the time, my quality of life would certainly suffer. And we don't, I know that we're all here because we're learning, but sometimes we don't, just to be able to sleep through the night is what a person wants. And it's bad enough getting to an age myself, I know this is being filmed, where I don't expect to sleep through the night. If there were additional reasons why, that would really be worse. So is anyone here who doesn't believe that a good night's sleep is important? Imagine if you can't sleep because of the pain. Now, for many years, and does anybody know when, just as an example, just to give you, so gabapentin, the first gabapentinoid that was FDA approved is gabapentin, and it goes by the brand name originally Neurontin. Does anybody know when it first came out? Or when, around when it first came out? You can shout out, we're all friends here. It was about that time. It was in the 90s, and it was in December or 1998 that there were there was a pivotal article published in JAMA supporting the potential benefit of using Neurontin in that form, gabapentin, for postherpetic neuralgia, and Well, I'll tell you what's interesting about that article, since I brought it up, and it's definitely off script, but that's what you got by asking me to speak today, because it'll make the point. In that study that was published in JAMA, and I think Michael Robotham was the lead author, the mean pain intensity level of people going into that study was between 6 and 7 out of 10. There was clearly, over the study duration, a better outcome in those who got treated with gabapentin versus those who were treated with placebo. And the average pain relief was about 30%. Mean was about 30%. So if you do 30% of about, I think it was 6.6 or 6.7 or something like that, if you forgive me for being off by a tenth, and you subtract it, you still have a number. So it's like, comes out to like 4 point something. So the mean pain intensity for even people who were successfully treated was over 4 out of 10 pain. And everybody hailed this study as a successful study because it was better than placebo. But here's the point that resonates with this slide. That's true, but it also meant that people who were still experiencing over 4 out of 10 pain intensity and still had postherpetic neuralgia, obviously, they would still qualify for the study the next day, meaning they were successfully treated, they had PHN, they had pain severe enough to start over the study after they had been in the study. So having to use another agent was known 20 plus years ago, and the fact that we are going to talk about the combination of a lidocaine patch and we're going to focus on ZTlido as a lidocaine patch, adding that to people who have already used gabapentinoids makes perfect sense if you look at it in that context. At least it does to me. And because we know that people have continuing pain even though they've been treated with a gabapentinoid. And so we do know still, if you look at different guidelines, neuropathic pain or otherwise, that gabapentin and pregabalin are still highly prescribed agents. Both have FDA approval for postherpetic neuralgia, and they have very similar side effect profiles, including dizziness, sedation, and others. And they sometimes limit the dose of the agent used to the point that survey data suggests that people, anybody know what the FDA approved dose of gabapentin is, gabapentin for postherpetic neuralgia? How much? No, for BHN it's 1,800 milligrams. But the point that was going to be made is that most prescriptions are for far lower than that. How many people here think, by show of hands, that if you gave somebody 325 milligrams of acetaminophen, you'd expect it to work? You laugh. But think if you're the patient who just got a prescription for gabapentin because that's all they can tolerate, and it's way below what's been shown and proven to be effective. So I know I'm dwelling on this slide to make the point that although it's FDA approved, it's not enough for many people, and it's not being used at a dose that is likely to help. And here is more formal data. 14% of people, this is our claims database retrospective analysis in the real world, 14% of people treated with gabapentin reached 1,800 milligrams per day. If someone said 3,600, that's for epilepsy. And so of those who added a therapy to gabapentin, 57% had an opioid added. Now, just by show of hands again, if there is a non-opioid option that can equally or better address a person's pain, please raise your hand if you believe that's preferred. Okay, it's not that you wouldn't use an opioid, but if it's preferred. Okay, all right. And when you look at pregabalin, titration took 9.2 weeks on average. This is the opposite of where, so I used to live right near where Billy Joel grew up. And of course, one of his famous songs is getting it right the first time, or maybe in the first week. I made that up in terms of his song. But this titration takes 9.2 weeks. You're the patient with a terrible pain problem. That's a long time, right? 27% of people, this is another retrospective data analysis, 27% of people treated with pregabalin reached 300 or more milligrams per day. And that's important because there are several doses that are approved for PHN, and very few, or 27%, reach the target doses. And of those who added a therapy to pregabalin, 58% added an opioid. So coming attractions. In the last slide and in this slide, I mentioned that there was that people added an opioid. Over half. Now, anybody know what happened a couple of years ago in terms of black box warnings? I'm going to show you a slide about this in just a second, but it's timely. What was that? And why is that? Well, just to put it more discreetly, you're right, you're good, because it potentiates the risk of respiratory depression. So we went from, okay, this is what's really happening, to now we have data that supports that people get added an opioid, and now we have black box warning that says, well, you know, if you do this, please be aware and make sure your patient knows that this can enhance the risk of the worst consequences of an opioid, which is respiratory depression. So again, if we can avoid that, that'd be great. So adding prescription oral analgesics comes to gabapentinoid comes with baggage. I kind of alluded to that fact with opioids. They're both, there's the black box warning I talked about, and there's also other concerns as well. There's also the possibility of tricyclic antidepressants interfering, and of course, there are side effects and drug-drug interactions, cognitive impairment, and dosing complexities when you add any of these. So what if we had an approach, and we could show that this approach actually works without having to add an oral agent, without risking those concerns that I just spoke about? So how could you do this? Well, we're going to concentrate now on using ZTlido, really a next generation lidocaine patch, to accomplish that. And let's see what data we can support that with. So ZTlido, when you see the 1.8% patch, it is bioequivalent to the 5% lidocaine patch. The Lidoderm patch, which is what the original branded 5% lidocaine patch was called, has 700 milligrams of lidocaine in 14,000 milligrams of adhesive, which is where the 5% comes, whereas ZTlido has 36 milligrams of lidocaine in less adhesive, and it has therefore a percentage of 1.8%. But they are bioequivalent. Okay, it's not related to they're bioequivalent. It's a way in which the drug is made. Okay, so ZTlido delivers the same lidocaine dose with 20 times less medicine. Okay, and there have been studies, including a single center pharmacokinetic study in 54 people, that showed that there was bioequivalence between the ZTlido 1.8% patch and the Lidoderm 5% patch. Now, this is an important point, because this important point helps to understand that the lidocaine patch can be used so this study evaluates the efficacy of a lidocaine patch, specifically ZTlido, with pregabalin or the combination of both. And so taking 98 patients with postherpetic neuralgia, they were either treated with pregabalin or ZTlido for 4 weeks with an assessment of pain relief. And then in stage 2, ZTlido was added to the pregabalin regimen, or monotherapy was continued in other individuals. Okay? And the stage 2, the addition occurred in people who had experienced insufficient pain relief. And if people experienced sufficient pain relief, they went on to continue with their monotherapy. Although the term ZTlido was used here, it was a lidocaine patch. Okay? Just to be fair. Now, with the addition of a lidocaine patch, there was a 48% reduction, and this was an 8-week trial using up to 3 patches daily to ensure that adequate coverage of the painful area occurred. And you can see that adding that lidocaine patch doubled pain relief. So after 8 weeks of this combination, people rated their quality of life as much or very much improved. So it was about a 78. I'm sure you're familiar with the Patient Global Impression of Change, or the PGIC score, and around 78% of people, people had about a 78% improvement in this particular measurement. By the way, everyone familiar with the 30% pain reduction as being a clinically meaningful pain reduction in studies? That came from analyzing the PGIC. That's where that number came from looking at pain intensity levels and PGIC correlation. So being able to say you're much or very much improved is an important metric. When you looked at sleep and function, this is evaluating ZTlido on sleep, quality of life, and pain in 265 patients with postherpetic neuralgia. You see, looking at assessments including the chronic pain sleep inventory, a 36-item short form of health survey assessing quality of life and function, and the short form of the McGill pain questionnaire, all at the SFMPQ, which also looks at function and pain relief. You can see that in this 8-week open arm, which is a subset of a study of a larger study or an original study, 265 people with postherpetic neuralgia received treatment with ZTlido if they were at least 3 months post-rash and had a mean pain intensity of 4 or greater on a 0 to 10 pain intensity scale. And they were allowed to receive for up to 3 patches per day, and they could stay on their concomitant and stable analgesics. And after 8 weeks of therapy with ZTlido, trouble falling asleep reduced by 74%, awakening by pain during the night reduced by 79%. There were noticeable improvements in quality of life, and there were improvements in emotional, physical, mental, and social functioning over an 8-week period. So why does this work? What might be, and how does ZTlido deliver these results? Well, you might say, well, let's just back up for a second. What organ of the body, and I'm not being biased in this, what organ of the body actually processes pain ultimately? The brain. So not only so you'd expect, hopefully, to be able to show that not only does an analgesic therapy or topical analgesic work locally or peripherally, but might it work centrally as well? And so I'm going to go through some information right now that really supports that ZTlido as a lidocaine patch has a dual mechanism of actions that's enhancing pain relief, not only by working peripherally, but also centrally. Okay? So that would complement the mechanism of action of a centrally acting drug like a gabapentinoid. So this is work done at where I went to medical school, Northwestern University Medical School, and it was done by a group of individuals who looked at pre-treatment, 6 hours of lidocaine patch use, and after 2 weeks of lidocaine patch use. And this is functional MRI data showing that with treatment, not only did pain intensity scale, not only did the pain intensity levels go down, but also if you look at the functional activation of relevant areas in the brain that process pain, anything that's less colorful means there's less activation. So you can actually see not only it's applied topically, but there's a central effect. And this was work that was done over a decade ago. Okay? And this supports the idea that the organ of the body that's experiencing the effects of that peripheral, it's showing that there are central effects also on the brain, which is where the pain is being processed ultimately. And it really supports, it disproves the idea that this is only a topical, only a peripherally acting agent. This is an agent, as a lidocaine patch that's bioequivalent to established lidocaine patches. That lidocaine patch works only at the skin. It dispels that. Now, this is a medication that works best when used on a daily basis, and not used when people skip the days. They can notice the difference, and so it's important to reinforce that. This has a technology, the Z-Tech technology, the ZTlido patch, and only the ZTlido patch, that ensures sustained skin contact for a full 12 hours. And I'll give you some important information about that. Does anybody think that a patch could work if it falls off or peels off? I know it's like a rhetorical question, but you'd be surprised how often they do. And ZTlido has demonstrated adhesion in accordance with a new FDA draft guidance. How many of you have read this? I'm only kidding, because who would read this, except unless you're developing in the special segment of the drug development industry. But there is actually a guidance assessing adhesion of transdermal and topical delivery system for new drug applications, NDAs, draft guidance for industry. And in it, it says adhesion is critical for drug delivery, therapeutic effect, and patient compliance. Decreased surface area of contact between patch and skin diminishes the amount of drug delivered and may impair efficacy. This seems obvious. And so the FDA draft guidance recommends adhesion testing for all new and generic transdermal systems or topical systems to demonstrate greater than or equal to 75% adhesion of the total surface area during the entire use period, and adhesion under water stress conditions such as bathing and showering. Because adhesion performance can affect both safety and efficacy of topical or transdermal drug systems products, because adhesion failures can result in reduced effectiveness caused by suboptimal dosing. Straightforward, makes perfect sense. So 29% of generic patches were completely detached versus 0% of ZTlido patches at 12 hours. Okay, and greater than 93% of were fully attached for the ZTlido, and 20% of the mean, 20% of the mean generic. So you can look at here that in a head-to-head study, superior adhesion was clearly demonstrated in the ZTlido. And if we go from the premise that a patch in this class can't work unless it's adhering, it's clearly in favor of the ZTlido patches. This actually is the first and only lidocaine patch clinically proven to adhere during exercise. So it stays securely attached during exercise. It was tested in 2 hours of biking. We want our patients to be as active as possible. We're not saying that everything is going to be solved with a ZTlido patch. We're saying that perhaps now you can go out and function and exercise and do the things you like to do. And in part, you can do this because it's adhering. I'm just giving you that as an example. And it also, conventional lidocaine patches are limited as they cannot be used when wet. And the ZTlido patch does continue to adhere despite water exposure. Now, I'm going to kind of wind up now before we go to questions and answers with another important part of where we started from, which was, if we recall, that when gabapentin and pregabalin users did not benefit sufficiently. They were over half of either group, gabapentin or pregabalin, were being prescribed opioids as well. And we all kind of agreed, I think, there was no one disagreed, that if you could have a non-opioid alternative, that would be good. And we talked about the ZTlido addition and the data that was supported with adding a lidocaine patch to somebody with postherpetic neuralgia who is on a gabapentinoid. So now what I'd like to do is see what happens in the real world, or what can we learn from claims data, from insurance information, from what's been used and prescribed when ZTlido and opioid use is compared to generic 5% lidocaine patch and opioid use, and which kind of populations are being treated with each of these, and what happens when you use each of these types of systems on opioid reduction. So adding a topical lidocaine patch can, in fact, decrease the use of opioids. So there was a 42% reduction in a cohort of patients prescribed strong opioids at 4 weeks after adding ZTlido. There was a 69% reduction in patients prescribed strong opioids at 24 weeks after adding ZTlido. So that points to two things. One, people are getting continued relief, and two, as a consequence of that, they're also on lower dose of opioids. So that's between 4 and 24 weeks. And this was an observational study in 273 people with postherpetic neuralgia who were assessing lidocaine patch use under clinical practice conditions. There's also a second study design that was used to calculate this data that was part of a German pain registry group, and data obtained from that. Now, this is different type of data. This is retrospective claims analysis data which evaluated the ZTlido patch versus the lidocaine 5% patch impact on opioid use. The study time period was May 1st of 2018 through September 30th, 2023, so that's where the data was looked at. Index event was the first prescription for ZTlido or the lidocaine 5% patch. And then when we talk about doses now, I'm going to be talking, the pre and post means 6 months before the prescription and 6 months after the prescription, during which there was continuous medical and pharmacy coverage. And there had to be at least one claim for an opioid drug of interest between October 1st of 2018 and September 30th of 2023 to be included. And inclusion criteria also included that the person had to have a chronic neuropathic pain condition in the pre-index period, and the person had to be at least 18 years or older at index. So the two cohorts, ZTlido and the lidocaine 5% patch. The methods was to analyze claims, as I mentioned. The endpoints, important, differences in proportion of patients who had a decrease or discontinuation of opioids between the two groups, and a difference in change from pre to post index opioid dosing measured with morphine milligram equivalents. So the difference in change in dose in the two different groups. And the statistical methods that are used are noted on the slide as well. Okay, so here's the outcomes. More patients discontinued or decreased opioids with ZTlido. So if you look on the right-hand side, the percent of people who discontinued or decreased, increased or no change in opioid dose in the post-index period. So decreased 51.9% if you were ZTlido, 45.5% if you were the 5% lidocaine patch. Increased opioid, 38.8% in the ZTlido group, 47.9% if you're near the 5%. So that's kind of looks at the heterogeneity of the patients we take care of. Many were able to come down, some were not. So more ZTlido patients had a decrease or discontinuation of opioid dose compared to lidocaine 5% patch patients. And of those who had a decrease, significantly more ZTlido patients had a 20% decrease or greater, a greater than 20% increase compared to lidocaine 5% patch patients. And that comparison was, each of those comparisons were statistically significant. Now, there was no increase in opioid dosage during the pre versus post index in terms of median MMEs. So if you look at the numbers on the right-hand side, the 4,365 or the 4,500 should be divided by 180, because that's the total number of milligrams over a 180-day or 6-month period. And so you can see that there was a non-significant change in the ZTlido group. That p-value is not significant between 4,365 versus 4,500, but there was in the 5% lidocaine patch group a significant increase, a statistically significant increase. So it started at 840 and went up to 1,200 over that period of time. So the first number refers to the pre-index, the second number refers to the post-index. In patients who had a decrease, there was a greater drop in opioid dose when you look at the ZTlido cohort. So again, these are individuals who had a decrease in opioid dose. So in patients who had a decrease in opioid dose, ZTlido patients experienced a greater than 1,800 milligram reduction compared to pre. So post was 1,800 milligrams compared to reduced compared to pre. And so the individuals understandably started at a lower pre-index dose in the lidocaine patch, the 5% patch, and but they had a lower dose, they had smaller reductions in dose. In patients with an increase, there was a lower percentage increase associated with the ZTlido cohort. So if someone did have a pain condition, neuropathic pain condition that did result in an increase in their opioid dose, and there were those, as I mentioned a few slides ago, in each group, those who were using the ZTlido patch had a lower percent increase compared to those who were using a 5% lidocaine patch. So ZTlido versus 5%, there was a difference. So just to conclude that from there, significantly more patients reduced or significantly more patients reduced or discontinued opioid dose in the ZTlido cohort compared to the lidocaine 5% patch cohort. So the ZTlido cohort had a non-significant change in MMEs, morphine milligram equivalents, whereas the lidocaine 5% patch cohort demonstrated a statistically significant increase. In this retrospective claims analysis, so it's retrospective, ZTlido was associated with less consumption of opioids compared with the lidocaine 5% patch, suggesting a better pain control with ZTlido. And of course, key limitations of this analysis is that it's not a prospective randomized controlled study, and the results should be interpreted in that way. Okay. So how can you replicate these results in the real world? Well, first, you want that you prescribe enough patches for your patients that are going to, or likely enough patches so that the painful area can be adequately covered. If you prescribe one and it's not going to cover the whole painful area, that's not going to work. So it's indicated, ZTlido is indicated for up to 3 patches daily. Okay, it should be used daily and not PRN. I tried to emphasize that point earlier, just want to emphasize it again. It's 12 hours on, 12 hours off for 24 hours of pain control. And it should be used daily for at least 8 weeks, because that's where we have our data. If we want to present, we have our clinical practice experiences, but the trials that led to the understanding of how to optimize the use of this medicine were based upon trials of multiple weeks, and the idea of using daily for at least 8 weeks is suggested so that we can get as close to possible at reproducing the positive responses that we're seeing in clinical trials. If a person says, I'm only using it for a week or two, I didn't feel anything, I'm going to stop using it, that person really, if there are no side effects, which are precluding further use, that really person should be encouraged, because based upon what we understand to be the optimal way of using this, to use it for at least 8 weeks. And there are a lot of medicines that need to be used longer than people would love to respond immediately, but there are many medicines that we use regularly that do require more time. So remember to advise patients before prescribing ZTlido that they should only use the number of patches prescribed, that it's 12 hours on, 12 hours off, and don't wear it longer than that. And people should apply the ZTlido patches to intact skin only. The indication is for relief or pain associated with postherpetic neuralgia in adults, and we talked about that earlier. It's contraindicated, ZTlido is contraindicated in people with a known sensitivity to local anesthetics of the amide type, which is what lidocaine is, or to any other component of the product. Accidental exposure can occur even after a ZTlido patch has been used. So what does that mean? And I'm sure you've seen this before in warning labels. Make sure that small children or pets do not come into contact with, and because they can, if they do, they could suffer serious adverse events from chewing or ingesting a new or used ZTlido patch. Even if after it's used, there is still medicine in the patch. So it has to be stored and disposed properly and keep out of the hands and keep out of reach of children and pets. Excessive dosing or exposure to lidocaine can occur. And so longer duration of application of more than the recommended number of patches Kidding, I'm not kidding. I once took care of a patient probably over 5 to 10 years ago who came in with 10 of these on her body. That's not, please advise against that. I don't know how this person even got them, but this does happen, okay? Because it could result obviously in lidocaine overdose, and we don't want that to happen. Cases of methylmeglobinemia have been reported with local anesthetic use in general, and application site reactions can occur during or immediately after treatment with the ZTlido. I'm sorry, I need to go through all these this important safety information. And hypersensitivity cross-reactions may be possible for patients allergic to PABA derivatives. And so we all know how to manage hypersensitivity reactions. Eye exposure with ZTlido should be avoided. And then adverse reactions. The documented side effects of ZTlido include application site reactions such as irritation, erythema, and pruritus. And these are not the only ones that may occur, but these are the most common. And so for further questions, if you want to check in a particular patient, look at full prescribing information. In specific populations, ZTlido during lactation should be used with caution because lidocaine is excreted into breast milk. And the limited human data with lidocaine in pregnant women are not sufficient to inform drug-associated risk for managing birth defects or miscarriage. And we get asked this question in our pain center all the time. We get referrals from OBGYN about how to manage pain, and it's admittedly really tough to really be able to provide any concrete information other than do no harm, because it's not we're not going to see studies. Let's see what happens if this, let's see what happens. Can you imagine a study being done? Let's see what happens when you use this drug in pregnant women? No, and who would want that to be done? So you have to be very cautious and understand that you have to be risk averse and that there are always concerns. And I always work very closely with my OB colleagues. So in summary, ZTlido can help break that vicious cycle of chronic neuropathic pain and postherpetic neuralgia. The clinical challenge is that gabapentinoids have been a foundational therapy, but titration to an effective dose is often unattainable. And I will add that even when you reach an attainable dose, the published literature supports that people still have residual pain that could be further managed. The benefits of adding ZTlido is that it doubled pain relief and enhanced quality of life. It helps patients sleep better at night and function during the day. It's proven to reduce the opioid usage. There are both peripheral and central mechanisms of action, and so that pain relief is enhanced in multiple ways. And the specific Z-Tech technology measures sustained contact and adhesion for a full 12 hours, and adhesion is key to successful use. So to optimize success, use ZTlido the way that it was prescribed, which is the right way, up to 3 patches daily to ensure adequate coverage of the painful area. Use every day and not PRN, and for at least 8 weeks. So this has been a promotional program, so if you have questions, which I'd like to answer, if at all possible, there may be certain questions that, according to promotional program guidelines, are not appropriate to answer in this setting, but we'll try to get you an answer in a different way. So with that, I'm happy to answer any questions that you have, and I certainly appreciate that you've spent your lunch with us today. So if you have any questions, there's a card. You can shout it out. Yes? Do we have a mic? Thank you.
Yes, thank you. On the brain scan, what areas of the brain did activity change with the lidocaine application?
So we can get you that data. We can get you, if you give me your email address after, I'll send you a reprint of that study, because I don't think listed on that slide are the actual areas, and I don't want to. I mean, the different areas of the brain that function during pain experience, include the amygdala, the hippocampus, the sensory processing area, the thalamus, and so that slide wasn't made to distinguish I can go back to it, but I don't think it was made to look at every single area, but that data is available in the publication that they came from. Sure. Did you have a particular reason for asking, or a particular? Well, you know, to your, yeah, sorry, I just went past it. So to your point, no, it's not, I didn't, well, yeah, it is. Excuse my old eyes. So the areas that were imaged here are the somatosensory cortex, the secondary somatosensory cortex, the orbital frontal cortex, but I think within the paper there are other areas that are imaged as well. But to your point, you know, what is pain defined as? A physical and emotional experience, or described in those terms. So you're 100% right. Pain is not just, that's the difference between nociception and pain, which is that the cognitive and emotional consequences of experiencing that sensory experience. So by definition, multiple areas of the brain light up where you'd be pinched, or if you were to, you know, stub your toe immediately. And imagine the effect of those processing areas over time if every day you're experiencing chronic pain. That's why it's so intrinsically linked that when we're in pain for a long period of time, we don't like it. But I can get you that paper. I have that paper. I can send it to you. Other questions, comments? Oh, great.
I'm just curious, like between ZTlido and the regular lidocaine patch, what's the difference? Like, is it because that ZTlido adhere to the skin better, that's why it's more effective, or is there any other factors that make ZTlido more effective?
So that's a really important question. The best way that I can answer that is in a couple of ways. First, empirically, we see superior outcomes in one group in certain settings than the other. Second, we know that the way for a topical system to be effective is through adhesion that's superior, and that can be demonstrably demonstrated. I mean, that has been demonstrated in formal studies that the ZTlido patch has superior adhesion. Remember that every time you use, people don't just get PHN in an area that's convenient to put a patch on. Sometimes it occurs across the joint or involves an area that's movable. And so the ZTlido patch has shown excellent adhesion, as mentioned in the studies supported that I just presented, as well as in my own clinical practice. Even if they are bioequivalent, the fact is that a patch that doesn't stick isn't going to work. It's also much lighter. Have you ever seen the difference between the ZT? I mean, my experience, the ZTlido patch is so much more comfortable for people to wear that perhaps an additional reason, in my experience, is that people will wear it more often. It's a very comfortable patch.
There's another question, Dr. Argoff. It's around, can the same patch be removed and then reapplied? Dr. Argoff? Yeah.
No.
After a procedure or an injection in the area?
No, I don't think I would not suggest that. I would defer to the package insert if there's any information about that, or if you have a specific question, ask medical affairs at Scilex if there is any experience, but I wouldn't support that just on the face of it.